Hello, good evening. This is Colonel Malish. I'm the commander of the Carl R. Darnall Army Medical Center here at Fort Hood. And today I'm going to be making a presentation on our QUiC clinic initiatives. QUiC clinic, as you can see on the title slide there, stands for Quality, Urgent, Internet, and Phone Care, QUiC clinics. And this is a switch in paradigm for all of our primary care clinics. But really, as you'll see, we're really focused on our community-based homes, and that's what we started with our QUiC clinics here at Fort Hood. You can see there I have the purpose outlined, and we'll get started. First of all, I have no disclosures, and this was the result of a performance improvement project, so there's no funding for this. This was something that we did in the course of our day-to-day duties. Here are the learning outcomes. We'll begin with number one, recognize how the quad aim is best achieved in primary care by fully embracing the behaviors encouraged by the capitation reimbursement model. And you'll see there's a little bit more to that than what I have there, but capitation actually encourages us to practice primary care in a way different from the way we're currently doing it. And I like to spend some time talking about what it is that capitation incentivize. Then we're going to explain how primary care clinics can optimize value-based metrics by adopting the QUiC clinic model. You can see again, I've described what QUiC stands for. And then we'll describe how providing urgent care at primary care clinics can offload a hospital's emergency medicine department with significant downstream benefits. And I'll spend some time at the very end discussing that. The next slide is the agenda. We'll start with just the tenets behind the QUiC clinic methodology. And then I'll spend a fair amount of time talking about our experience here. Because at the end of the day, we took a process that had been piloted, a successful pilot, and then we validated it across our Central Texas market, including 5 different clinics, all with very good results. I also want to spend some time talking about, and this is the third bullet there, how an accountable care organization like the front office, the command suite here at CRDMC, how that level of leadership needs to get involved in order to make the process work. And then again, some secondary QUiC clinic benefits. So the next slide is going to talk about something that we should all be well aware of. And these are the things that we profess we value in the military health system, the quadruple aim. And I always like to go over this. I know everybody that's listening to me has gone through this a number of times. Of course, in the middle there is increased readiness, and that's what makes us special, is that we're here to support our national defense. The better care portion of the quad aim, I always like going onto the MHS and DHA website and looking at what exactly the definition of better care is, because what I found on the site is that experience of care is the thing that is first mentioned. Quality and safety are mentioned, but they come after the experience of the care. And I actually think this is a good thing. I think what it's saying, it's making the assumption that quality and safety are something that are immutable, that we're going to do them no matter what. By putting experience of care up first, it's telling us that we need to, that's an area of focus. And I don't know that we do a great job in the military health system with the experience of care, but the quad aim encourages a good experience of care. Then you'll see population health or better health. And that's something also that I think makes us unique, although other civilian medical systems are getting after things like that. But it's prevention. And if you're, and I know agencies like Kaiser, for example, are getting better at that. And there are some things with, for example, the MACRA and things like that where prevention is encouraged. But by and large, this makes us different as well, because most medical systems gain revenue by people getting sick. But that's not what we're here to do. We're here to make sure that people are as healthy as possible for as long as possible at the most fulfilling level of health that they can be. And if they don't get sick, then we're all for that. So population health there, the second portion, or the third portion of the quad aim, and then lower per capita cost. And that's just saying we have to achieve the increased readiness, this better care, this experience of care, and this preventive mission to make sure that people are at their healthiest possible, this population health mission. We have to attain it all without breaking the bank in terms of the taxpayer dollar. So we have to strive for efficiencies in the way we provide care. This is the quad aim, and this is what we value in the military health system. However, is that exactly how we're built in terms of our system, our infrastructure? And when you look at how we're built, I would argue that we're actually not built to provide our patients, our enrollees, our teammates, our empanelments, the quad aim. We are built for productivity. And where productivity would be important is if you were in a fee-for-service methodology, if you were a civilian hospital trying to build insurance companies for revenue. To stay afloat, to pay your bills, to pay your civilian, your staff, etc. That's actually the model that I believe that we're configured for. And how does it manifest? We encourage maximum attainment of RVUs, relative value units, by our providers. The more work they do in our minds, the better we are as a system. In the second bullet there, you can see our electronic health record, or ALTA, is actually built for us to try to attain as much workload as possible. We get classes on coding. Coding is something that we track very, very carefully. Coding what? Not for the benefit of the patient, but to ensure that that we're doing as much work as possible. It's all built there as well. Our templates. If you look at our primary care templates, and things are always changing, so we're getting better at this, and I want to acknowledge that. But during my time in primary care, our templates have been built to funnel patients into face-to-face appointments, preferentially, because that was the method of getting higher RVUs, doing more work on that patient so that we could document more work so that we could get paid more. And we would fill, and we continue to do this, we fill all of our day from morning till late afternoon with face-to-face patients and do work upon them that we put in the record to show that we're doing a high amount of workload. And then you'll recall that no-shows are considered bad, et cetera. So the system is actually built for productivity, as though we were in a fee-for-service model, which we're not. We're capitated. And so you can see we have conflicting incentives, productivity, and those things that we say we strive to attain, which is the quad aim. And this slide is just trying to depict that the productivity incentive is actually stronger in many ways. It's the way our system is configured, and it makes the attainment of the quad aim much more challenging. I want to go on to the next slide because it will show you what we're faced with the fee-for-service type of system. Now, this is a very complicated slide, and I'll take a little bit of time to walk through it. You will see several columns, and at the top of each column is the name of the day of the week. The first row in the column should be thought of as the first appointment in a day for a provider, and the 20 minutes at the very bottom is the last appointment of the day. And so this is a template. At the top is the morning, at the bottom is the end of the afternoon. Our templates are built in 20-minute increments to bring patients into the hospital or clinic to see them face-to-face. This is how we see patients. And so when we think about seeing somebody in the future, we say, we'll need to see you back in a future appointment, and we will put them into one of these slots. And we do this for a reason, and that is because every time we see a patient, we can work to attain as many RVUs as possible. What we're not good at doing is saying, why don't you call me back next week? Or why don't I call you back next week? Or why don't I follow you up with an email? Because if you look at this grid, you can see there isn't the time in the day to have those types of interactions. The system is it allows us to preferentially put patients into these appointments. And so that's our problem. We are configured for fee for service. Another way to look at this slide is to not think of every column as a day of the week, but think of it as one day with 5 providers. So this is a clinic now, think of it differently. A clinic's templates, morning to evening, top to bottom. And now they have 5 providers on duty. Routine care has been put in every single one of the patient slots, 20-minute appointments. Now, what happens when somebody comes in who's sick? We are so jam-packed with with routine care, we find it easy to say, no, we can't possibly see you now. Look at how busy we are. You have to go either to the emergency room or find someone else to take care of your acute care need. That's when our patients are sick. That's when we need to be there for them the most, and yet we let them go elsewhere. And to me, this is tragic in a way. Tragic is a little bit sensational, but what kind of a healthcare system fills its day with the routine things to such an extent that it doesn't treat patients when they actually aren't feeling well or they're injured or something like that? And I'm not saying it happens intentionally. It happens unintentionally, but it's a byproduct of the system that we've configured. Also, because we've got these 20-minute appointments from morning to evening, we don't have the time nor bandwidth to really focus on those quality items, those preventative things that are part of the quad aim that'll keep patients out of the clinic and out of the hospital. And so we're stuck in this loop. So that is the problem, as I see it, and it's not universal, but it is a problem with our current healthcare system. So what is it that how are QUiC clinics different? So I'm gonna spend just a minute with this slide because this is everything in a nutshell. And if you can leave with the only one message here, I would say this slide is all you need to leave with. And so we're gonna look at QUiC clinics in 2 different ways. Our goal is to create clinics that embrace quality. And quality, we measure it in the MHS through HEDIS metrics. And that's how we're going to make sure that we are providing quality care. And then we're going to have urgent care features so that we can always see you when you're not doing well. You can always walk into a QUiC clinic because we're configured to be able to take care of you at the time that you're ill. We're not going to jam pack our day-to-day business with routine care so that we're incapable of seeing you when you're sick. So all of our QUiC clinics are in fact urgent care centers. And we achieve the goals of quality and urgent care by shifting routine appointments into the virtual space. This is internet and phones. So that is the acronym, QUiC, and the C at the end is care. These are QUiC care clinics. That's going from 1 down to 3. Let me read it back to you and go from 3 to 1 because I think this makes it even simpler. We shift as much routine care as possible. This is a lot of care, by the way. This is follow-ups. This is a discussion of referrals. This is receiving referrals. This is talking about referrals and follow-up. This is talking about labs. This is talking about studies, radiology work. This is a lot of the care that we provide. We shift all of this, not in a face-to-face dimension, but into the virtual space through emails, phone calls, and now V3s, virtual video visits. We put all that care there, which is a much more efficient way of seeing these patients than bringing them in. And with the time freed up by doing that, we create the capability for urgent care and the time and bandwidth to obsess about quality. So that's reading from bottom up. And that is QUiC in a nutshell. It's simple. It's very, very simple. It's not challenging. It's not difficult. It's a bit of a rework of our current model because we're not looking at all in what we're doing and how much work is being done. And in fact, I will often tell my providers, don't kill yourself. Remember what the note is there to do. The note is there to document the patient's condition and to document the assessment and plan for what you're doing. So don't make it too difficult on yourself. Don't make that note something that's a billing device in which a lot of work is done that has no benefit to that patient. And so it is a bit of a switch. So I want to move on to the next slide because it'll show you how things are different. Okay, you'll see on the left, that's the current system, the face-to-face appointments jamming up the day with routine care. You'll see those little red figures. Those are the sick patients who we don't have the bandwidth to see. And you'll see the green little figures are is the capacity right now that we're using for virtual medicine. SMS, by SMS I mean secure messaging system, TCONs and the like. It's a small minority. And yet we know, and it's a well-known fact, that more than 50% and often 60% of medical care can be done through information exchange. It does not require hands-on. So what is QUiC? How is QUiC different? Okay, and now go over to the right and you'll see that there's a white space there. This time is not booked with face-to-face patients. And you can see in the first I guess it's 80 minutes or something like that, that provider saw 6 patients in the time that it would take to see 4 with face-to-face. Quick, efficient bursts of information, taking care of patients, by the way, in a place and time that works for the patient without them having to navigate our parking lots, our front desks, our waiting rooms, all that work. We're taking care of those patients, we're communicating with them, we're getting their needs met in those bursts, and we're seeing much more of them in that time frame. We continue to see face-to-face as needed for all those patients that need hands-on follow-up, that we want to listen again to that murmur, we want to look at that rash, et cetera. We continue to keep face-to-face follow-up appointments open. And within that white space, not only do we take care of the routine care through virtual, but we are open and available for those sick patients to come in. So again, we free up white space by taking care of much of our demand, all of our demand that can be done with information bursts. We don't route them into appointments, face-to-face appointments. We take care of all of that virtually. We reduce the demand for our face-to-face time, and that frees up the capability and the availability for sick patients to come in. Just remember what QUiC stands for. Quality, urgent care, internet, and phone. And by the way, in that white space, that gives our teams time to focus on those HEDIS metrics. And this again is the prevention, keeping them well. And I'll just take a second to, let's go to the next slide here. I'll just take a second to talk about capitation. Capitation is diametrically different from fee-for-service. In capitation, you get a one-time payment for whatever the billing period is for that patient. So the goal of capitation is not to bring patients in to code as much as you can off of them. It's to keep patients out, because when you bring them in, you expend overhead costs in taking care of them. So a well-capitated system would work very, very, very hard on prevention and keeping patients well. And that's what this system does. And by the way, also, a capitated system would want to be that patient's choice again and again as a healthcare plan. And so they would strive for patient experience, a great patient experience. So a capitated system is the right payment methodology for what we're getting after. We just haven't converted in our minds yet, in our infrastructure and the way we work to get into capitated payment. But the Army's been doing capitated payments in primary care since 2013. So we're behind in terms of following up that strategic message with operational changes, and that's what QUiC clinics do. This is what a QUiC clinic looks like, again, using that previous sort of infographic. This time, however, this is one provider, and it's showing how we free up white space for that provider and make sure that at all times people can walk in, that we're obsessing about quality, we're obsessing about patient experience, et cetera. I just want to let the audience know that, that this has been piloted in a community-based home, and this is the article that was written in 2014. And it turned, the results were incredible there, and you can see that the clinic excelled in HEDIS metrics, secure messaging took off, and the patients were highly satisfied with this model. And so it says, please remember these patterns, because as I go later on into the briefing, these are the patterns that we want to see as we premiere QUIC clinics across the footprint. But this is a validated project, and I recommend this article to you because a lot of thought went into how do you train a clinic, how do you change the climate and culture from one in which work is valued to one in which the value of what it is that you're doing is something that you strive for. This is just a taxonomy. If you're capitated, again, you want to create a clinic that's very efficient, and you want your patients to continue to select you as an insurance plan over and over again. So you must keep your patients happy, and part of that is always seeing them when they need you. They have to know you're there, waiting for them with arms open. So always seeing the sick keeps patients coming back to you as an insurance plan. And of course, our insurance plan doesn't really provide these choices, but these are the things to which we strive. And then you want to see them rarely. And how would you do that? Just the very same things as QUIC. You would use internet and phone, emails, et cetera, for most of your communication. And then you would strive very, very, very hard to make sure they stay at the highest level of health so that you don't have to expend any of that small lump sum that you get for them and taking care of their illnesses. So this is economics in a lot of the senses. So so it's all there, and then that article is a good article to get the basics. This is a motivational tool. There's 4 things that absolutely must be done every single time with the QUIC clinics. And this is and we have these on our badges, et cetera. And I always take this out and I say, okay, these are the things that we must do. If we're failing on any of these, then we have to readjust our sights and get back after it. But here's what they are, and this is just going to sound just like the QUIC sort of description all over again. We will always see you when you're sick, and that is a mandate. Our front desk, again, we should be striving for a fantastic customer experience, a great customer experience. And by the way, this means empowering people. Our MSAs, in my opinion, are not empowered to help problems. And again, I'm speaking in generalities. And there are plenty of places where MSAs are just doing fantastic work and they're well empowered and the teams are all linked together. But I've always found it funny that when there's a bad patient experience, the answer is to go get MSAs better training. No, the MSAs need to have tools to help patients. In other words, they should be able to walk a patient in and say, hey, I can tell you're frustrated, you're not feeling well right now. Please have a seat. The provider will be with you shortly. Those are the types of tools they should have. And then we should embark back at them as providers. If I truly care about the patient experience as the OIC of a clinic or the OIC of a hospital, I have to be accountable for that. And I have to provide my employees all the tools they need to take care of that patient on the spot. So this is a cultural change. And for example, what I tell these QUIC clinics is you can't blame, or you can't say the MSA is the problem. No, you're the OIC of the clinic. And this is a big portion of the quadruple aim. This is what our strategic leaders are telling us to do. It's inappropriate to say, I need to give more customer service to this MSA that's, by the way, doesn't have a lot of tools in their toolbox. Anyway, we have to work towards that, and I want leaders involved, and by leaders I mean the entire clinic striving for a good customer experience. And then you can see the other 2 things there have already been talked about. Commit, and by commit I mean really shift all that workload into a virtual environment, take care of all that demand so you have that white space open. And then during that white space, not only see patients who are sick, but obsess about HEDIS. Just a very, very simple, it's almost elegant in how simple it is. But those are the messages. I just want to let everybody know, if anybody is interested in QUIC, it's all there for you. It's all been put into a box. So you can call us here at Fort Hood, and it's also available from Regional Health Command Central. But here's a little story. This was something that the OTSG was interested in. The Chief of Staff up there at OTSG and MedCom was very interested in piloting, and we worked on, when I was up there as a staff officer, at getting it ready for scale and spread. which is overcome by events, by the DHA coming on board and different things happening. But the bottom line was that we have prepared a complete set that you can call us up and we'll give it to you. And it includes a draft operations order, which is basically the recipe for switching a fee-for-service clinic, our current format, to where we need to be, to a QUiC clinic. It gives you how to go from where you are to where you want to be, because there's a transition that's not easy, not necessarily easy. It can be to get from fee-for-service methodology into the QUiC methodology. But there's a process that you have to go through. We have got all the training in there. We've got marketing tools. We've got posters. We've got advertisements. It's all there. And we've got a couple of guides on how the accountable care organization needs to think about QUiC clinics as well, because this needs to be top-down driven. Just a quick note on the Central Texas market. You can see here that we have on the left, we're dispersed in terms of our primary care. We've got 9 primary care homes, and we've converted all of those that are in that tan color into QUiC clinics. These are our community-based medical homes, and these are the model. They have the staffing model, the NCQA staffing model that we switched to in that op board that came around back in 2012, I think it was, when we went from our previous paradigm into primary care medical homes. And so these are staffed according to the model. The only difference is now they've changed their behaviors to get after QUiC. You'll see on the left, we have soldier-centered medical homes. Those are in the process, the early stages of transitioning to QUiC too. It's a little bit of a different process because of a number of reasons. There's a different command that needs to be bought into it. And there's different tensions, et cetera, there. But they're in the earlier stages of going through QUiC. The 5 on the right, and you can see the Russell Collier there is half green, half tan. That's because it has a soldier-centered medical home portion and a community-based home portion. We switched the community-based home over to QUiC there. But they're all fully onto QUiC by now. They're all doing QUiC methodologies on a day-to-day basis. And here they are dispersed again, the soldier-centered medical homes on Fort Hood. And then beneath the highway there in yellow and tan are our community-based medical homes. And again, you can see the QUiC symbol for all those community-based homes. Okay, I'm going to skip this slide. Okay, so this is critical. How do you know if QUiC is working? And I'll go on. Again, we focus on the quad aim. And so you can see here that there's 7 measures that we look at. 2 are measures of performance. So they indicate whether we're getting close to what we want to be, but they're not as good as measures of effectiveness. Measures of effectiveness are telling us that we're attaining those things that we strive to get after. So meaningful patient touches is a measure of performance. It's similar to RVUs in a way, but it's basically how many patients did you go out and reach and touch in a day. And the hypothesis is with QUiC Clinic, because you're using much more efficient means of communication, you'll see more patients in a day than what you will with the legacy paradigm. That's a measure of performance. It's interesting and it's relevant, but it's not necessarily important. But what about experience to care? We consider access to care as an indicator of experience of care. Are we there for you? Are we available for you when you need to be seen? So that's a measure of better care. And then patient satisfaction is really where we're measuring the experience of care and better care. And so we're going to look at 3 Joe's scores there. The 23, which is, I always get these confused. 23, I think, was how would you rate your appointment visit? 24 was, would you recommend that facility? And we also look at 25, which is, were you able to see your provider when needed? So these are the 3 things that we look at very, very carefully as a measure of effectiveness to see whether we're improving things by switching to QUiC. In terms of lower cost, we look at leakage. And if our patients are coming to see us, which we want them to do, we should see less leakage. If we're there for them when they're sick, We shouldn't see any of our patients going to urgent care centers on the outside. And why is that? It's because we have a market, we have a competitive advantage over any urgent care center, and that's that we are their docs, and they are our patients, and we should just exploit that. And I think that leakage is a good mechanism of seeing whether we're their place of choice for care. And then enrollment, and I'll just talk very briefly about enrollment. That's sort of a pacing measure. I include it because what we don't want to see is the attainment of the other 4 measures of effectiveness at the cost of lowering enrollment. So we don't want to convert ourselves into executive medicine or concierge type medicine where we're focused on a small elite class of people, and so we can do everything for them at all times. We have to maintain our current empanelment, and so that's a pacing metric. And I just watch that metric to make sure that we're not getting after these other things by lowering our workload, by decreasing our enrollment. And by the way, our enrollment for all of our providers in these QUIC clinics is 1225, which is well within the DHA recommended range. Population health, better health, this is prevention. We look at cancer prevention and the management of diabetes through A1C, and we're starting to look a little bit at the behavioral health measures in HEDIS as well. And then a measure of effect of performance again is whether the staff is satisfied. So, but really what matters the most is these measures of effectiveness. And please notice, nowhere on here is there any measure of how much work did you do on a patient or how many RVUs did you accumulate for billing of a fictitious insurance company, which frequently they are, because at least here on Fort Hood, the vast majority of our patients don't have outside insurance. So these are the metrics that must be measured in a value-based system. This is meaningful patient touches, that first measure of performance. And this is what happened when we switched our initial clinic from the legacy model into QUIC. I'll just bring this up. The providers are seeing more patients in a day. In blue is face-to-face, in yellow there is TCONs, and orange is walk-ins. They're seeing, you should see some, and this is over time, by the way, so, and there's 2 rectangles. The one to the left is the legacy system, and then it moves into time, into the future, and the one to the right was the new QUIC clinic. The overall height of the columns, these are the amount of patients touched per day, increases with the QUIC clinic model. And it does this because more are seen through TCONs, this was before V3s were there, and decreases face-to-face. And now you can see creeping in there is orange. And these are the patients that need to see us because they're sick. These are walk-ins. And this is what a QUIC clinic should look like in terms of meaningful patient touches as you turn it on. You decrease face-to-face, you increase patient contacts through virtual mechanisms, and there in the middle of it, the outcome is urgent care capability to take care of your patients. These again are these the metrics, and this is what the metrics looked like at our original pre-QUIC clinic where we made our first conversion. And you can see they're just all over the place, and it doesn't appear to be anything acting on the system. It's an uncontrolled system. That's not completely appropriate as a descriptor, but it's a system that isn't fully focused on the quad aim. I'll put it that way. And I'm going to move to the next slide. Again, this is just how we transitioned. We transitioned one in November, and the rest came in the spring of this year. And I'll speak in a different presentation, by the way, about how COVID actually really helped us to get transitioned in this. But you don't need COVID in order for you to get moving in this direction. Okay, the next slide I'm going to show you is our results. And I'm going to spend a bit of time on it because I think it's really sort of the important point from this. Okay, these are those value-based metrics. And this is shown over time, dating back to when we first started, when we first got here in July of 2019 to where we are now. And on the top row is patient satisfaction. These are our patients telling us about their patient experience. Question 23, these are survey questions, 23, 24, and 25. And you can just see that there's a trending upwards, and that red line, by the way, is 95% or higher, which is a ambitious goal, but it is the correct goal. And you can see we went from, and this is in the summer of 2019, hanging out in the the lower ranges, and then with QUiC now, our patients are more satisfied, and we continuously flirt with the 95% standard, which is a very ambitious goal, one we can't attain, and we're continuing to iteratively improve the patient experience. I'll just remind you, the 3 questions that we ask is, how satisfied were you with your appointment? Question 23. Would you recommend this facility to a family member or friend? 24. And were you able to see your provider when needed? This is our patients telling us across the 5 clinics that we're providing a better patient experience. I'm not going to spend a lot of time on meaningful patient touches again, because that's a measure of performance. It helps you see whether your clinic is converting, but it's in the grand scheme of things, it's not a value-based metric. Okay, next row, you can see HEDIS trends. And that red line now is if you're doing, and the HEDIS trends are listed there: breast cancer screening, for example, diabetes, A1C being maintained less than 8, cervical cancer screen, and colon cancer, et cetera. The red line there is if you're in the top 10% of the nation as compared to last year's benchmark. You can see that we were actually pretty good before, but now in every single one of these metrics, these measures, we are performing above the top 10% in the nation. And this is prevention. These are getting after the things that are going to keep our patients well into the future. And again, these were the things that I considered most important. And now we've expanded this to the major depressive disorder HEDIS metrics and moving on. You can see our enrollment. It's a slight downward trend, but no significant changes. In other words, we didn't attain these goals by limiting our enrollment. You can see our access to care well below for futures what the standard is, 7-day standard. And we're very, very close to the 1-day standard with 24 hours with our acute access to care. One thing I'll say about this, though, we always see patients when they need to be seen. We never turn a sick patient away. And so whether or not there's an appointment there for the auditors at the end of the day is important, and we try to make sure there's appointments available. But it's not completely accurate if you're looking at whether there's access for our patients. We have urgent care centers, there's always access. And then you can see our leakage numbers are going down as well. So again, these are metrics, and they come directly from the quadruple aim. RVUs are not encouraged. We attain them through these QUiC tenets that I will recommend you go back to that one slide that I said was everything, and that's how you're getting after it. And these are the results of that across our five community-based homes, our QUiC clinics. I'm going to go through the next slides very quickly, because these are just there to show you that we obsess about these metrics one by one in each of our homes. And I sit down with the leadership in primary care, the other deputies, DCA, everybody else, and we look at each of these clinics one by one, and we see where we need to help these clinics get after QUiC methodologies. And all of them have slightly different problems, but they're all focused on the same North Star, which are these 5 metrics. Okay, I just want to spend a moment here. We asked our staff, are you satisfied? Is this a better paradigm of care than the way we were configured before, the legacy system? And these are 5-point Likert questions, and you can see what our staff said. And I would rate all of them as very positive. In their opinion, patients like QUiC, and we've already seen that, by the way, in the Joe scores. QUiC enables better care. On a scale of 1 to 5, the majority of our providers, in fact, almost all of them, had a positive response to that. QUiC methodology is better than previous, that's a green, and QUiC is sustainable, and that's a green. The one area that we learned from, and this was the first clinic that converted, was that one in yellow, and that was the clinic given all the tools that they needed. And this was an important lesson for us as we move forward into the next clinics as they transition to QUiC. We actually found out that we weren't well configured to get into that internet and phone space. We didn't have enough webcams. We didn't have enough iPads, for example. We didn't have the software. We were using VA Connect as the platform in several of our clinics. but we need it in other clinics, and we just didn't have the IT backbone that we needed. And so as we moved this out into future clinics, we made sure as we got ready to transition that we had laid the groundwork, as it were. And this feedback helped us understand how to premiere QUiCs. Okay, I'm going along here, but this is one major point that I want to make about QUiC clinics. So what did QUiC clinics do? They created urgent care capability at every single one of our primary care homes. And this has impacts beyond that particular clinic. And so how does this manifest itself? And let me see if I can get this straight, but with urgent care at all of the homes, there's no longer a need for patients to go, and I've already talked about this, to civilian urgent care centers, but even better to go to the ER for low acuity level 4 and level 5 type of complaints. And so what we did was we put a position there. It's called a patient liaison, but I call it the QUiC quarterback inside of our emergency department. This is a patient liaison who works normal hours. Once the patient comes in and as they're being triaged, as soon as we find out that they have a primary care problem that can be managed at one of our QUiC clinics, we ask them if they prefer to be seen there. And frequently they do, because there's less of a wait time. And again, it gets back to that competitive advantage. They would prefer to see their doc then they would want to wait, 2 or 3 hours, 4 hours, 5 hours in the emergency department. So we're redirecting, or we're reversing flow from our ER back to our urgent care centers. Whereas before, because we were so jam-packed with routine care in our primary care homes, the flow was going to that choke point, which was the emergency department. And so a lot of good things are happening. And by the way, every time a patient shows up at the ED with a low acuity problem, the ED quarterback educates them as well and says, hey, I don't know if you know it or not, but your patient-centered home has all the things that you need for this, and they're ready and willing to see you. So this position might not be enduring. Once our patients understand to go to their primary care home for their urgent care needs, the need for a QB quarterback or an ED liaison might go away. But it's really dispersed care, urgent care, all the way back to these clinics, and it's caused a change in the dynamics of our healthcare system. So there is a lot of goodness with QUiC clinics. And again, for the teams that are out there, there's no cost to it. The cost is in education, training, et cetera, but none of this was done by plussing up the current infrastructure of the clinics, apart from IT, getting the IT where it needs to be in order to handle all of the video virtual visits and SMS, et cetera. But I would argue that we need to do that anyway. If we're going to be a competitive healthcare system, we need to, sort of advance into the future. But there's no cost to it. In other words, all you have to do is order this kit from Regional Health Command Central. We'll provide it to you, and get it in place and get on your way to value-based care. So, and I'm open for questions and et cetera. I just need you to send me an email. My email is available on Outlook. I'm Richard Malish. And again, I want to end by saying the team at QUiC is unbelievable. And we've got great leaders here. And I think they definitely deserve all the credit for making this process work at our local level. But it's something that any team can do. So I look forward to hearing your comments and feedback. Okay, this is Colonel Malish out.